they have implemented clinical simulation and virtual clinical simulation during the COVID-19 pandemic. Our first presentation is from Homestead Schools, and that will be presented by Adele Blanco and Edwin Canetti. Adele, are you with us? Edwin, I can see your video is on. You are muted, however, at the moment. You can unmute yourself. You're both muted.
I am here.
Hi, Adele.
Hello.
Thank you. The floor is yours.
Okay. Hi, good afternoon, everyone. In the period of pandemic, we should always be COVID fine. So I am COVID fine. I am Adele Blanco, the DON of Homestead Schools. There is an advantage and disadvantage to be after lunch presenter. It is either you'll pay attention to me or sleep through the presentation. Thank you for allowing us to present our virtual simulation clinic. I want to commend all presenters this morning. All of them are excellent. This afternoon, Mr. Edwin Canetti, our simulation coordinator, will be presenting our virtual simulation clinic through the video. We created a virtual simulation clinic by researching and hard work of our clinical simulation coordinator, the chief academic officer, DON, and of course, our owner who approved our budget. So this afternoon, our objective is, at the end of this short presentation, the participants will learn that moderate fidelity simulation is as effective as high fidelity simulation in the clinical experience instructions in our students. So if you could play our video, Mr. Edwin will be there. Hello, Shelley.
Yes, is Edwin ready for the video? I see he's still muted.
He's ready. Huh?
Okay.
He's muted. Can you unmute him? Are you muted? Okay. Could you play our video, please? Thank you.
Welcome to Homestead Schools Virtual Clinic. The Homestead Schools Virtual Clinic is designed to facilitate clinical sessions in a controlled environment, allowing students to incorporate acquired skills from previous terms. Students will have the opportunity to think on their feet and make clinical decisions when critical events are presented to them. The school uses Zoom as the main application for this virtual learning environment. Sessions are recorded in the cloud. The breakout rooms, polling surveys, and live chat features make this tool vital to learning. The school also uses the learning management system called Urban. Here, all sessions are made where memos, assignments, assessments, and discussion forums can be created. This is the platform used to give feedback to students' submitted work and to assess students' learning through online tests. The Homestead Schools Virtual Clinic is equipped with different simulators. For this presentation, we have used the Nursing and Simulator from Lvnrpt. This mannequin's main feature is its modular platform that allows customization to accommodate varying scenario needs. A summary of its features will be shown toward the end of the presentation. We have also fitted the virtual clinic with a simulated electronic MAR equipped with a barcode reader. The virtual clinic also has high-definition webcams, unidirectional mics, and a sound system. The Nursing and Simulator also features tetherless operation that connects wirelessly to a patient monitor. This provides concise clinical feedback that simulates physiologic parameters. A scenario planning sheet is prepared and discussed by instructors facilitating the simulation. The student's level is clearly defined so that expectations and goals can be set. Some prerequisite knowledge may be needed, especially for the attainment of a higher level of learning. In this example, Term 2 students are selected to perform the simulation scenario, HIV/AIDS with complications. Supplementary reading materials are also provided to students and disseminated through Urban in preparation for the simulation activity. A brief summary of the scenario is included in the planning worksheet. At the end of this simulation, the student, for example, will be able to recognize the need for increased oxygen administration, explain procedures to the client using an appropriate communication framework, and describe appropriate evaluation of the client outcome. An outline of the proposed correct treatment is also included in the planning worksheet. Here, the critical events are identified for which students are expected to react and make decisions regarding the best course of action. You can see here that changes in pulse, respirations, temperature, and oxygen saturation can trigger appropriate focused assessment decisions for the student. Lab reports like CD4 count can further add complexity to the scenario. Basic information about the patient is made available during pre-briefing. This helps the students pre-visualize their patient before their actual encounter. By understanding the clinical setting, the students are better able to decide priorities of care. The patient monitor may be set to be viewed in different ways. For this presentation, the patient monitor is set to show a basic display typical of a medical unit. By displaying these parameters, the students are able to collect valuable data about their patient. During pre-briefing, the students will be shown this typical display. They are taught what the numbers mean, as well as the upper and lower limits that are set for each parameter. Another important aspect of the planning worksheet is the checklist for fidelity modulation supplies. This is needed to enhance the realism of the scenario. The planning worksheet also includes the preparation of the simulator. For the nursing and, there are several default states that can be used. The results are recorded, and the roles of the participants are identified. Physiologic trends can also be created in a timeline to identify critical events that will trigger a response from the students. This serves as a roadmap for scenario progression. Once a critical event is initialized, the students are expected to respond, and they are evaluated for the appropriateness and timeliness of their responses. This part of the planning worksheet shows the references used in the development of the scenario. The mechanics for running the simulation are shown. 2 instructors are assigned to facilitate the session. One instructor will be in the simulation lab operating and directing responses from the mannequin and the patient monitor. The other instructor is in the virtual classroom on Zoom, directing and instructing students. The patient description and scenario background are given during pre-briefing. Since there will be 2 students each runtime, they are randomly assigned a partner a few minutes before the start of the scenario. Furthermore, students are instructed to verbalize their actions clearly. With the use of a rubric, the instructor records the student's score based on what they said they did or decided to do. At the end of the session, students will join the debriefing where they will reflect on the actions and decisions they made. Likewise, they will complete and submit clinical worksheets discussed later in this presentation. Here's an excerpt of the scorecard for a particular pair of students. They can get a full point if they are able to verbalize an action independently. A fraction may be deducted when additional audio or visual cues are provided. Students are made aware of this setup during pre-briefing. For this presentation, the scenario involves a 32-year-old diagnosed as HIV positive and has been under close outpatient supervision because of persistent fever, pulmonary infiltrates, and non-specific flu-like symptoms. The client is admitted to the medical unit for fever, chills, sweats, myalgias, malaise, chest pain, non-productive cough, axillary adenopathy, nausea, vomiting, and severe diarrhea. The admitting vital signs and diagnosis are shown. Once the students are ready, the simulation scenario begins. Here is an excerpt of the simulation scenario participated by a pair of students.
Yes.
Yes, okay, good. All right, good morning, Lorena.
Good morning.
Right, my name is Edwin, and I took care of Mr. John Cooper last night. He was admitted through the emergency room. He's a 32-year-old male who came in with intermittent coughing and fever, but he does have a history of being HIV positive 3 months ago. And so the admitting physician is Dr. Smith, and he thought it wise to admit the patient for additional workup. So that was yesterday. Early this morning, last night he was not able to sleep very well. So, I try to give him the best care I could. He was coughing intermittently. His vital signs this morning are 109/84, heart rate of 104, respiratory rate of 30, and an oxygen saturation of 96%. His temperature was 103.5, for which I gave acetaminophen, 500 milligrams. He has an order for an antibiotic uh, twice a day, so the first dose was given today. There were some labs ordered early this morning. Results are still pending, and the chest x-ray was done at the emergency room. Activity is ad lib, diet is normal. Doctor ordered vital signs every 4 hours. Oxygen, he's receiving 2 liters via nasal cannula, 2 liters per minute via nasal cannula. Other than that, he is resting comfortably, and no other complaints at this time. Okay?
Okay.
All right. So go ahead.
So, okay. So I would knock on the door and introduce myself to the client and ask his name and birthday, and go ahead and wash my hands. Would the way I'm explaining it, would Justine need to be there too, or is it?
Yeah, it's like you're talking to the patient. Okay? And from time to time, I'll be jumping in as the narrator, but you are doing it like you're talking to the patient. Okay. But remember, he's he was tired from last night, so you may want to be just asking him, "Is your name John Cooper?" And then I would just click on his response, right? Okay, go ahead.
So I would say, hi, I'll be your nurse for today. My name is Lorena. Is your name John Cooper? And I would check his wristband and wash my hands.
Yes.
And then
Okay.
close the. Oh. Okay. I would wash my hands, and then I would ask him, how are you feeling today?
Okay.
Are you feeling any pain?
No.
Okay. And then oh, he's coughing. Maybe I could ask him if he's been coughing through the night.
Clinical worksheets are provided to students to enhance their learning. So this is an example of a concept map worksheet where they can fill up the boxes in their own words. If they handed off the patient's care to another practitioner, they will continue using the SBAR format. This slide shows the document that the student can fill up using this format. Knowledge of the medications administered is also important. This worksheet is used to help the students master the drugs along with the relevant information regarding their use. This section of the clinical worksheet is similar to the nursing care plan. It contains background information about the patient, including the shift goals and patient education needs. This section of the clinical worksheet further enhances the student's ability to prioritize the care by focusing on the most important need. Likewise, there is a portal on Urban where the students can upload their documentation assignment. This is an example of the student's submitted text. The instructor can give feedback directly to the student through this platform. Reflection is an integral part of the debriefing. Guided reflection questions are provided for students to respond. Their responses can be uploaded to this portal as well. This is an example of that students submitted responses to the guided reflection questions.
Thank you. And we've now reached the question and answer time slot for this presentation. So we will open the Q&A panel. Again, board members, if you would like to make a comment, you can do so by raising your hand or posting your comment in the chat. And to the public, you can post your question or comment in the Q&A field by clicking on the Q&A icon on your screen.
Okay.
Yes, this is Alita Carpenter. I'm sorry, but I was unable to hear any of the entire presentation. I turned every single auditory device I have up as much as it would go. Could the other board members actually hear? Is it just me? What was going on?
Hi, this is Ms. Rooks, and I also could not hear. Thank you. So it seems based on some of the responses we've got that some people could hear it and some were unable to hear it. I have several people that have let me know they could hear it. So I apologize. I'm not sure what is going on. And the ability for everyone to hear. Seems like a mixed bag of who could hear it and who could not. And we do have a few questions that have come in. I will go ahead and ask those while we have a couple minutes left. How have the students responded is one of the questions we've received.
Ms. Adele, you want to answer that?
The students really enjoyed it very much, and they said that because of the fact that it's not, they're not scared to say something or to perform and not thinking that they can kill a patient, that was a very good learning experience. They're actually very excited about it. And plus, they're not scared of having COVID, so they have more learning opportunities with our simulation lab.
Overall, it was a positive experience for the students. They thought that the experience gave them the opportunity to think and be more engaged. And the amount of preparation that was given to them actually gave them the ability to proceed with the simulation as seamlessly as possible.
We would like, if people would like to call us and speak with any of Mr. Edwin or me, just leave a message and we'll call you back. And we will help you as much as possible. We did have a lot of them preparing, a lot of preparation, 6 to 8 months for this, and we're good as far as our simulation lab. And we're very proud of it. So you can call us and we can answer your questions.
This is the moderator. We have a question that asks, how many students participate at a time in these sims?
So for the simulation, it's for the entire clinical group. A group usually consists of like 10 to 12 students. And then the runtime, about 20 minutes, is performed by 2 students at a time. So that fills up almost the 8-hour day. That includes the pre-briefing and the debriefing in the end.
All right.
You hear me now?
Oh, yes, we can hear you.
Okay, every time I try and run a video, it messes up my microphone. Okay, my apologies. Thank you, Adele and Edwin. We're going to be moving on to the next presentation now. Thank you so much for yours. As a reminder, the video presentations and links will be made available after today's meeting, as well as responses to any of the questions that we were not able to address live. So the next presentation is by Unitech College, and it will be presented by Janice Holt and Dr. Cher Prairie.
One moment while I get them promoted.
Good afternoon. I just want to say thank you to the board members for allowing us to present this material. And Dr. Prairie is going to start off.
Thank you so much for listening in. We're quite excited to share what we did at Unitech to kind of bring everything together. Luckily, we had the ability that Unitech was able to partner with some of the things that you heard this morning. But we took it one step and said, okay, we have all of these wonderful technologically advanced products. What do we do with them now? So next slide, please. So what we started out with was thinking about what do we do with this? So we have all of this, we have this technology that we have available to us, but how can we really make it count for the students? So we brought it back to what did we really want from the clinical experiences besides the students to have hands-on practice. And part of that was to really encourage students to critically reason. And critically reason involves the ability to actively and skillfully conceptualize, analyze, question, evaluate ideas and beliefs. In other words, it's really clear thinking. So the term clear thinking, I like because when it's used, you know that when you ask a student a question, someone with clear thinking can really rationally talk you through their processes and their conclusion. Someone with clear thinking understands the links between ideas. They determine the importance and relevance of arguments and ideas, recognize and build and appraise arguments. Are they saying the correct thing? And they identify inconsistencies. So they approach problems in a consistent way. So that's what we wanted to build upon, while also using some of the items that you guys heard or saw this morning. So next slide, please. So we started out by really looking at the pre-conference. And the pre-conference, as you guys know, is so very important. I feel like it's just as important as post-conference because we really want to set the tone for the day. And pre-conference in a virtual clinical simulation becomes so important because you want the students to be clear on what outcomes you're looking for that day. So again, we're looking at setting up some of the skills that they need to be able to critically reason. So they want to really focus in on their observation, their analysis, and interpretation. So we want them to think about the scenario that they're going to see in an objective and critical way. We want them to identify arguments or be able to speak to things in a relationship to a particular issue that they saw on the scenario. So all of those things we kind of set up in the pre-conference by asking them some critical reasoning questions. What would you do if the patient fell in the shower? What would you chart? What would you start looking for as far as assessment? Who would you call? Those are the kind of things that we start really looking at in the pre-conference. Next slide, please. So then what we would do is we would send the students off to do shadow health, and we would give them a specific assignment. For example, this is some of the assignments you guys heard about this morning was on shadow health. And shadow health we were able to partner with during the pandemic. And one of the things that we could do is we could have the students go and work on Brian, who was admitted for chest pain. And this provides the opportunity for the student to conduct a focused exam on a patient complaining of chest pain, whereas we couldn't make someone have chest pain out in the real world. So this was a great opportunity for students to be able to have this experience. They have to really think about emergency interventions, interview the patient, assess the body systems that are appropriate, and then complete those post-exam activities. So a little snapshot of the first part. Next slide, please. Yes. The next part of this that we put a picture of was basically the pre-brief scenario that students would see, and this is their preceptor Diana, that first person that they would talk to when they came into the scenario, and she kind of gives them an idea of the scenario and the assessment that they have to do. But shadow health, one of the nice things that it evaluates multiple aspects of the student's performance, both subjective and objective data, asking the correct questions. Did they correctly chart the data in the electronic health record? You know, did they obtain all of the material all of the information that they needed? You know, are they asking all of the questions, and are they asking it in the appropriate way? One of the other nice things about shadow health is that we can go in and see the transcript of how either the student asked the question verbally or they typed it in. So there's multiple different ways that students can complete these assignments. Then they had to educate and empathize with their patient. They had to then develop a nursing diagnosis, create an effective care plan, and then evaluated their own results. How do they think they did? Which is so very important in critical reasoning, to self-assess. How were they doing? So then at the end part of shadow health, one of the assignments that they can have is to complete a care plan for the patient. Next slide, please. So this is one of the things that they can do is we had a small video, but with some of the issues that we're having, we're not going to show that right now, but one of the things that they can do is they can look in the eyes, they can check for pupil dilation, they can listen to lung sounds, they can listen for heart sounds, they get to see an EKG strip, they can give medications, they can do all of those things depending on how we set up the scenario, which makes it very nice. So this is just an example of a couple of things that students would see on the screen when they're completing these scenarios. Next slide, please. And now I'm going to let Janice Holt take over on the next portion of our plan.
Thank you. Okay, for this portion of it, it talks about things that we have integrated into our simulation to help the students gain a better understanding of the process. How are they looking at the behaviors performed in the simulation setting? And in the post-conference area, as someone mentioned earlier, it's meant to be, the debrief is meant to be a safe environment for the student, but we really want them to do a self-evaluation and look at what actions were performed and how we can improve. So here, this is just one example of integrating multiple components from the presentations you saw this morning. So here we have data from ATI. So the faculty are able to go in and possibly add a short quiz based on some of the material from the simulated experience and provide that to the students, and then evaluate the students' response in some critical areas. Next slide, please. Once again, here we're using ATI to help the students, as it says, connect the dots. It's one thing to just perform something kind of rotely versus really getting a true transfer of knowledge and understanding how the medications play into the management of the patient with specific disorders. What are those nursing interventions based on both the disease state and the medication that they're administering? So here we have a side-by-side template of the medication sheet used in ATI and a system disorder. So this is very similar to a concept map, and it allows the students to really take a deep dive into both of those areas. Next slide, please. Here is an example of Docucare. So this is an electronic health record. Students are able to document and view the health record in Shadow Health, but we also supplement our laboratory and simulation experiences with Docucare. This really allows the students to have a well-rounded experience in electronic health record systems, which is so important when they're licensed, when they're out in the real world, they really need that experience. Next slide, please. And then post-conference. So as I mentioned earlier, post-conference, we really want to try to hit on some key areas. Is the student able to recognize why the clinical data is relevant and why? How is the clinical data presented going to help them prioritize their patient care? Students also can develop a short care plan with 1 to 2 nursing diagnoses, as well as focused assessments. So this really will help guide the student into looking at what is the patient problem, how, as the nurse, am I going to intervene? As mentioned earlier, in using this in conjunction with Shadow Health, the instructor has the ability to pull that transcript and see step by step what did the student complete. One thing I really love in Shadow Health is it grades the students on their expression of empathy, which I think is really important in helping students develop that communication, with a real patient in a clinical setting. So this is a way to simulate that experience in a virtual environment. Once again, we're going to look at the interventions the student has completed, both in the transcript and other items assigned during the post-conference. We can also use group discussion and print presentations to supplement and reinforce that material. And that's all I have.
So the great thing about this combination of products, and again, Unitech really focuses in on making sure that we address some of the areas that maybe have been brought up in meetings with some of our clinical partners. One of those being, they wanted us to make sure that students had more time using electronic health records. So this was a great opportunity for us to really focus in and make sure that students had that electronic health record experience. So Unitech does a great job of providing students with a lot of different technologically advanced products that we can use, but it also, we kind of summarized it up into really focusing in on critical reasoning and clear thinking. We aimed it at achieving the best outcomes for any situation, and they had to involve gathering and evaluating of the information, especially from many different sources. So it wasn't just that they got the data from Shadow Health. Maybe they followed up and the faculty used Docucare, and then the students could go in and look at different lab values. So maybe it was a continuing case study where they had day 1 of Brian being in the hospital, but then on day 5, the students had to go into Docucare and see what changes were made in the lab values or the doctor's orders. So that was a very unique way of looking at this. And then the critical reasoning, it's also an assessment of their own personal strengths and weaknesses, their own preferences, and talking about adding empathy into their conversation with the patient, some students didn't feel comfortable, adding those kind of words into it. And so this was a good experience for them to be able to do it in a non-threatening environment.
Mm-hmm.
It also requires them to use foresight as much as possible to kind of start thinking, okay, what would I do if? Those if questions and why questions, and implementing the decisions that they made maybe in the case in the care plan, and then we could go back in and change some things up and see how it worked, and then evaluating those changes and see how the patient reacted to it. So it was a good experience. It required a lot of pre-work on the faculty's part, and it did require some outside of the box thinking, but I think we did a really good job of trying to combine all of the products together to increase critical reasoning.
Mm-hmm. And as as Dr. Crary just said, I think this in conjunction with other tools is a great experience for the students, even before they go to clinical, because using the talk feature, it allows them to really interact with the patient and test out, some of their communication skills before they're in a live clinical setting. So either way, with the pandemic or without, I think it would be a great supplement to the students' learning experience.
Thank you, ladies. We're now going to move into our question and answer session. So for board members, if you have a question for Janice or Shara, you can either raise your hand or type it into the chat field. For all of the other members viewing from our public attendee list, you can use the Q&A panel. And again, you can find that by clicking on the Q&A icon on your screen and then typing your question directly into the text field. All right, first question we have is, what resources do you have for students who are having difficulty getting onto one of the Vsim sources?
Oh, that's a great question. Not only does Shadow Health ATI, Docucare have their own assistants, but we also have our own help desk at Unitech that students can reach out to, and some wonderful IT people who worked very, very long hours, especially at the beginning of this, where students would need assistance with trying to get things taken care of. So very much so the IT people at our school helped out a lot.
And can I just add one thing? In order to kind of limit the student having multiple logins, when we transitioned, we instituted the Canvas learning management system. So we were actually able to work with Shadow Health, and we uploaded the links directly into the Canvas course where the scenarios would be used. So I think that too was a big help in ease of use for faculty and students.
And how many students participate at a time in these sims?
Oh, that's a great question. So we limited or tried to limit it to 1 to 15, but each student goes in and does their own simulation. So they do it individually, and then they come back for pre or post conference. So pre-conference was 1 to 15, and then they went and did their own sim, and then they came back for post conference.
Okay, and then how do you correlate your didactic teaching to clinical learning activities when using Vsim?
That's another great question. What we did was we took our curriculum, and then myself and another program director went in and we did all of the scenarios on Shadow Health, and we made sure that the information that was being presented in the Shadow Health simulation matched with our curriculum at that time. So we assigned them to particular parts of our curriculum.
Okay, and I think we have time for one more question. How are faculty trained and supported with the various sources?
Shadow Health is absolutely great, as well as ATI. We meet with them regularly. Any new faculty undergo a training session so they can become comfortable using those products. We also have developed faculty mentors who are the key resources in case any faculty need assistance. And I think that's been a great transition for us into the virtual environment. And so far, it's working well.
Great. Thank you, ladies, so much for your presentation today. We really appreciate it. We've now reached the end of our time for this presentation, and we'll be moving on to our next one. Our next presenters are from Miracosta College, and it is Jacqueline Fritz. And Jacqueline, I will share. Try to have it up. Would you share my screen? And Jacqueline, are you going to be talking us through this, knowing how our audio is not working?
Yes, I will be.
Okay. All right, floor is yours.
All right, can we go back one slide? There we go. Okay, can you hear me okay?
I can, yes.
Okay. Hi, everybody. Thanks so much for having us. My name is Jacqueline Fritz, and I am presenting on behalf of Miracosta College Skills and Simulation Lab and our hybrid model that we sort of developed as we went along through this COVID-19 challenge. And I wouldn't have been able to do any of this without my fabulous team, Sue Simpson, Julie, Denise, Shelley, Deb, and Maria. Next slide. So I'll just start out by saying, you know, in the spring of 2020, like everybody else, COVID closed our doors, and our team asked the question, you know, how can we continue to bring the nursing lab to the students in a personalized yet virtual format? And we were also immediately trying to think about how we could reopen our doors safely. And so the next couple slides are going to be explaining some of these formats, which are the virtual skills labs that we ran, some very simple skills tutorials that we developed, and a system where the students could actually bring the lab home. And then we also knew that when we did open our doors in summer of 2020, we knew that we needed a solid plan that anybody coming into the lab knew that there was a standardized procedure. Next slide. So our virtual skills lab. So when we had our initial lockdown and students weren't able to come to campus, we did speak with the students via Zoom, and we listened to their concerns, and a lot of them were so worried that they were going to forget how to do their skills. I think students are already so insecure about their skills anyways, and so the idea of not being able to be in clinical or be on campus to practice just really shook these students. So we tried to figure out a way, well, how can we still stay connected with the students and interact with them so that they can feel like they're still practicing. So the virtual skills lab was quite simple. As you can see in the picture in the upper right hand corner, that's me just on a Zoom meeting The computer's there. Students can see me in the lab. I would have a variety of activities available for the students to choose. So they would say, oh, I want to practice wound care, or I want to practice how to give a sub-Q or IM injection, and they would walk us through the steps. So it was a very interactive way for the students to still sort of feel like they were doing the skills. Next slide. So in addition to the interactive format of the Zoom, we decided that we wanted to sort of kind of add on to this and really kind of create our own MiraCosta community of learning. So our program already did have the ATI. We did have a lot of the fancy virtual sim platforms, but we thought, why not film some skills tutorials in our very own lab? So I have this little ditty here, relevant over fancy. These were not fancy videos by any means. I actually just used the Zoom platform to record the videos. And students really seem to appreciate these. They love seeing their own instructors in their own lab. Once again, it was just a way for them to still kind of feel connected to campus while they were stuck at home. My tip for these is to use your institution's checklist. So at MiraCosta College, we have a skills checklist, step-by-step checklist for all of our skills. So we made sure to follow those for our videos. I think I was going to attempt to show one, but with the audio.
If you'd like.
Oh, you said we can?
Yeah, I can attempt it. I tried to adjust some audio settings on my end, so we can give it a whirl.
Yeah, maybe just like a little.
Let me know if you hear it.
Okay. So it doesn't seem like you can hear it, but there is the transcript. And as you can see, the point that I'm trying to get across is I don't think that you need lots of bells and whistles to create these videos. The students really just want to know how to do them. And like I said, we have such a great team. It wasn't just myself. We all kind of took turns being in these videos, and the students really seem to appreciate them. And we uploaded them to our Canvas platform and what we call our nursing student hub. So all these videos were in one place. And you can go to the next slide. So bringing the lab home, we received a grant to purchase 36 of these Laerdal multi-task trainers. So essentially they're very simple. They're cardboard boxes. On each side, there is a different component to practice a skill, such as wound care, O2 application, Foley, ostomy care, injections, trach care, NG insertion. And so this was a great revelation for us that the students could take these home and still practice. Each box we filled with the necessary supplies that they would need to practice these skills. And even as we've opened up our doors, students still really appreciate checking these out, especially, with the COVID still happening and schools still shut down. A lot of our students that are parents that can't make it onto campus for open lab practice, they can check out one of these boxes and still be able to practice at home. Up in the left-hand corner here, you can see a student review. She says, these kits are awesome and really helpful. I wish we would have had these ever since I started in my first semester. I think I would have gotten a lot more practice done. So I really feel like this helped to facilitate the confidence that our students have in their skills, despite the pandemic. And a little tip I will say is we used just a simple Google Doc form to keep track of who, where these were getting checked out to, and that way students can log in, see when they checked it out, and see when it was due back on campus. Next slide. So in the summer of 2020, we decided that we were going to open up our doors in a hybrid fashion, prioritizing when the students would come in. And this was for our LVN to RN transition program. This took a significant amount of planning. We knew we needed a clear written plan, and we knew that this needed to entail a collective goal and standardize operations. So this is just a picture of what we created, the MiraCosta Nursing Lab COVID-19 Action Plan. And so this encompassed, the goal, room capacities, and I'm going to step you through the next couple of slides where I will explain this. Our collective goal was essentially that it was our obligation when opening our doors to keep everybody safe while continuing to provide the best learning experience. And I knew that the minute we started letting our guard down on any of the rules, that it would just be a slippery slope for the students and the staff to not have the confidence that our lab was safe. And also, it would jeopardize our ability to stay open. You'll see in this photo, some students practicing safely 6 feet apart. Next slide. So the standardized operations starts with the student check-in. So our campus has sort of evolved into now a much more high-tech version of their check-in, but initially it was sort of up to us to screen everybody and do the temperature checks. And once we have the health screening done, then we inform them, the students and the staff, again, of the health and safety rules. And then students are assigned to a certain part of the lab with their assigned faculty. Part of our standardized operations was having clear signage posted around the lab. So we found pretty quickly that we sort of had to constantly remind students, okay, remember 6 feet apart, remember, da, 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 da. So the signage certainly does help. And the message I wanted to come across in this sign is, look, we want to continue to stay open. We want you guys to continue to come and practice, but if you don't follow these rules, that's not going to happen. So that was, as you can see in the top line, your cooperation with the MiraCosta campus safety rules will assist us in keeping our lab open. So far, I can say that we haven't had any outbreaks in our lab, and I think it is due to these standardized operations and having this signage. Next slide. So what we try to do as much as possible is spread. We were very fortunate to have a fairly large lab where we could spread the students out and assign them to what I called stations or pods. And so students would go to their assigned station with their assigned faculty, and they would essentially stay there for their assigned time to practice the skills for the day. And so so everything that they would need would be at the station, all their cleaning supplies, all of the supplies for the skills that they were practicing that day. Everything is at the station. The signage is clear, and that way students and faculty aren't having to migrate around the room constantly looking for this and looking for that. Everything's right there. The students remain with their same group. Now, some days, you know, due to supplies and equipment, students will have to rotate stations, and I just suggest for that you know, you just gotta plan to have a right amount of staff for cleaning in between, and you really do need to have one person sort of overseeing these things, making sure the cleaning is happening, and sort of monitoring the distancing. Here's a photo of students practicing socially distanced, and you will see in the corner another one of our one-stop shops, I call it, all the supplies needed for the day and all of the cleaning materials. We have found as we've gone through to now that when students are up and practicing at these stations, it's a good idea for them to just have their eyewear, the face shield or the goggles and the mask, because it's just when they're up practicing in their pods, they just have a tendency to not stay the 6 feet apart all the time. So it's better to be safe than sorry. We just have them wear their face shields or their goggles in addition to their face masks. A big part of the procedures was determining how many students could be in a certain classroom at a time, up and practicing. So it really just involved getting the measuring tape out and taping out how many students could be in the classroom, depending on how many workstations and mannequins and beds you have. So by determining these numbers, this is sort of going to dictate your planning your days. So if you have a cohort of 28 students, a lot of the times that would involve splitting your skills days into two days, or one group comes one half of the day and one comes the second half of the day, and you can rotate them through that way. One suggestion I do have, we are very lucky to be in beautiful San Diego area, and the weather's nice. We have doors and windows, so we open those up and air it out. We try to provide as much proper airflow in our lab as possible.
And just a reminder, before I go to the next slide, you have just about 3 minutes left.
Okay. When we did transition back to open lab, students, of course, wanted to get back to the traditional open lab where students can practice their skills. Traditionally, students, we would host, once or a few times a week, a couple hours for them to come in and practice. But we knew that we had to limit the number of students coming in for that. And so we went to an appointment only open lab. So we created this Google Doc, and each week we plan out what times are available for students to come and practice. Students put their name under the time slot that they'd like to come in. We keep these time slots very short. We've noticed that if you do like a 2-hour slot or above, students just kind of come in and hang out. So keep it short. If you give them an hour, they are on task practicing. They come and they leave, and that gives us plenty of time to accommodate for cleaning in between groups. This was my last slide. I didn't get too much into our simulations that we've done during COVID. We have done just virtual simulations, most of which the faculty have done, through the platforms that a lot of which we've seen today. We have experimented with filming our own simulations in our lab using our camera system, but we are looking forward to bringing students back in small, very small groups for in-person simulations again. I really hope this offered your campus some ideas and inspiration for getting your students back on campus, and some simple ways you can supplement with a lot of the other platforms we've heard from today. Thank you so much.
Thank you, Jacqueline. We're now going to open up for questions. Reminder, board members, you can raise your hand or utilize the chat feature to submit your questions. Members of the public, you can submit your questions through the Q&A section by clicking on the Q&A icon on your screen. I'll ask my moderator, are you seeing any questions in the chat field?
This is the moderator. I am not seeing any questions. Amy Vermillion does say great information.
I'm sorry, what was that?
Oh, there was a comment saying that the information was great.
Oh, okay.
My apologies.
And one question, what has been the students' response with being able to practice at home?
I would say the moment we started sharing this idea with the students, they were like, oh, like, wow, this is great. They felt relieved that they would have that option, especially for a lot of our students who work full-time or have kids. So I think the response has been nothing but positive, really. We've been really happy with the results.
All right, and one more question before we're out of time. If a student struggles with performing a skill at home, how are they supported?
I think having our skills videos that we've created are super helpful. And students are always able to reach out to any of our lab and skills simulation instructors. But I think overall the videos combined with the checklist give the students what they need to perform the skills.
Thank you so much for your presentation today, Jacqueline.
Again, as a
reminder, if anybody's questions did not get answered, we will be following up on those after today's meeting. We will proceed now to our next and final presenter in this section of the program, and that's going to be from Riverside City College. Presenter will be Gina Weeks and Dr. Amy Vermillion.
Hi, can everybody hear me?
We can.
Yes, we can hear you.
Okay, thank you.
Hi, good afternoon, everyone. I'm trying to get my video going here. Hold on. I don't know why it's not doing it. Of course, right?
WebEx is giving us all kinds of fun today.
Okay, well, as long as you can hear me, I guess that's all that matters right now. So I just want to say thank you so much for letting us come on and share some of what we're doing at Riverside City College. I'm joined here with Dr. Amy Vermillion, who is our director of Simulation and Technology at Riverside City College. And so like the other colleges that presented earlier, you know, we had our challenges with the pandemic. And so as educators, you know, one of our main concerns is that how are we going to ensure that our students are getting those experiences that they need to really be that safe entry level nurse during this time. So we are going to present on how we kind of reimagine simulation during the pandemic. And so this is kind of how we are responding to the call that is out there right now. So during this presentation, I will turn it over to Dr. Vermillion, but you know, we will discuss how we transitioned our face-to-face simulation experiences to that online format, and also demonstrate techniques that we use to foster student engagement and learning. So we look forward to sharing our experiences and our strategies with you, and some of the methodologies that we used in meeting our student learning outcomes. So Dr. Vermillion, I will turn it over to you.
Okay, thank you. And it's great to be with you all. So to give you a little bit of a background, we had a robust face-to-face simulation program. We were very fortunate in May of 2020 to have earned the Society for Simulation in Healthcare accreditation for teaching and learning. And so we were actually one of the second programs that did an accreditation over Zoom, if you will, or in a remote environment. And so we were very excited about that. But with the pandemic, obviously our face-to-face simulation program was halted in March of 2020. And we have not thus far been able to return to on campus for our simulation activities. But the faculty really, along with the students, really believed in the importance of us continuing our simulation program. And so it really caused us to network with our California Simulation Alliance colleagues, our Society for Simulation in Healthcare colleagues. And so we began to reimagine how we would do this in a virtual environment. With the resources that we currently have, our students, when they were in the face-to-face simulation, they used Docucare as all of their patients were uploaded into the Docucare system. And so we wanted to continue to integrate that platform. And in addition, our students, through grant funding, all of our RN and VN students were provided with iPads. And so this did help us with moving to this virtual simulation environment as well. Next slide. So our overall process was we needed to get approval from the Lvnrpt for simulation, specifically for the vocational nursing program. And so we were able to successfully do that and submit the necessary documents so that our NEC could do that review. Like I said, we collaborated and networked with other simulation colleagues through the California Simulation Alliance and the Society for Simulation in Healthcare. We also solicited our faculty. We knew that we could come in and audio and video record using social distancing practices and wearing masks. And so we needed faculty to come in and help, along with our simulation lab specialist, who normally helps operate the simulators when we are in a face-to-face environment, for audio and video recording of our simulation scenarios. We then recorded all of our simulation scenarios, and the way that our simulation scenarios were developed is we have a educational resource and technology committee that we then created a simulation task force off of that committee and looked at different NCSBN data, looked at practice data, and then chose more of concept-based scenarios that integrated with our program curriculum. And so we had already had a simulation inventory of different simulations that were threaded throughout the VN curriculum. And so those simulations were recorded. Now, we did use faculty in the role of students. So the faculty were not scripted so that it was very, what I want to say, not so scripted that it wasn't authentic, but based on doing these simulations, we knew what some of the common areas that students at that level would struggle with. And so the faculty were able to act, if you will, in the role of that student. Then I created simulation PowerPoint slide decks and instructional materials that are disseminated during the simulation experience. And then we trained faculty who would be facilitating the simulations. So as part of our accreditation for simulation, we have to have documentation of professional development and faculty training. And so our faculty who facilitated the simulations had already undergone those particular professional development opportunities. But in addition, they were, they paired with myself and they were able to see the facilitation of a simulation in the remote environment. And so I was able to mentor them through that. And then we facilitated all our simulation experiences through Zoom with the support of our simulation lab specialist. So while we're not in a face-to-face setting where he is actually running the simulators, he is helping to run the video and help with the dissemination of the instructional materials to the students through the chat. Next slide. So our overall process, each facilitator is given a script, and with that script, it outlines basically, it orients the facilitator to the simulation. It also tells them the start and stop times of when the videos need to be started and stopped. And then it also links with the pre-brief and the PowerPoint slide deck along with the simulation case flow. Next slide. So this is an example of the facilitator script. Like I mentioned, it says the first 20 minutes of the simulation, the facilitator is going to go through the pre-brief script that is provided for them. It also reminds them to have the students sign into Docucare so that they have access to the patient's chart as the simulation scenario is unfolding. We have embedded QR codes into the PowerPoints so that the students are able to just simply take their iPad, click on the camera icon, and scan those QR codes. And this is how we disseminate the S-bars so that they can follow along with and make notes on, as well as the observer tools. So it's also a way to help to keep them engaged in the experience. And then, like I said, it gives the video start and stop points, as well as the vital signs that are on the S-bar and some probing questions, such as after viewing the handoff report, what are your initial thoughts regarding this patient? What do you think your priorities of care will be? Is there information that you didn't hear in report that you wish you would have known, as an example? Okay. It also, on that facilitator script, it also tells them what, after the handoff discussion, that the facilitator needs to assign the observer roles and what cues that they will hear for the video to go ahead and start. Next slide. This is an example of our pre-brief script. This happens to be on our fundamental assessment simulation. It's a standardized script. So the students are familiar because every pre-brief, regardless of the simulation, has basically the same information in it, with the exception of the simulation scenario's objectives. Okay, this particular simulation has two different states, so it unfolds. So the objectives are stated for what the objectives are for state 1 as well as state 2, but it covers the students' expectations of how they're supposed to participate in terms of psychological safety and how we are ensuring that they can feel safe to learn, what their role will be during this simulation activity, and then the confidentiality of not only their peers and their peers learning, but as well as the patient's case or the care of the patient that they're caring for in the simulated experience. Next slide. Like I said, the facilitator slide deck, it has QR codes. You can see to the right side. I know it is a little bit small on the screen, but you can see the QR codes that the students will scan those QR codes for the observer tools, the S bars associated with the different states of the scenario, and every scenario simulation experience, we have a link to the simulation evaluation in which we collect data on SurveyMonkey. Next slide. This is an example of the case flow. So it gives an overall overview of the simulation scenario. It gives in the far left column, it gives what that patient looks like in the room. What the operator needs to do, so that would be our simulation lab specialist, different triggers, so that if the student asked certain questions, information could be given, as well as the critical performance elements. And most importantly, that the facilitators really appreciate are the debriefing points for each state of the scenario. Next slide. So the way that we facilitate this is a screenshot of the video recorded simulations. Like I said, these are faculty who are acting in the role of that student. We do it by clinical groups. So we have 10 students per simulation scenario. And each student is assigned an observer role. And so based on the objectives and the student learning outcomes for that simulation activity, we also, because our student learning outcomes are very closely linked with the cues and competencies, we identify which cues and competencies or which lens that student's going to look through. We call it the CUSIN lens. So for example, if I have 10 students, 2 students may be looking through the lens of quality, safe, patient-centered care. 2 students may be looking at teamwork and collaboration. 2 students may be looking through the lens of informatics. And so they have specific observer tools that have specific behaviors that they are looking for. And if it's an unfolding case study, we rotate those observer roles. So if in state 1, I was assigned quality, safe, patient-centered care, state 2, I would be assigned the lens of teamwork and collaboration. And so the reason we do this is it makes the debriefing very rich. And it gets the students to really key in on those cues and competencies that, like I said, directly align with their student learning outcomes and the objectives for the simulation activity. The students have 2 views of the patient room and interaction, as well as the patient monitor during the when we play the video. Next slide. So our typical simulation schedule follows this scheduling grid, if you will. We pre-brief every simulation. It takes 20 minutes. Each scenario is 15 minutes. So you'll see in this particular case for our fundamental assessment, scenario 1 was 15 minutes, and then we debrief that scenario for 30 minutes. And then scenario 2 lasts 15 minutes, and we debrief scenario 2 for 30 minutes for a total time of 2 hours and 10 minutes. Now, if we need a longer time for clinical, we then incorporate the Docucare charting and differing activities, or students will do a nursing care plan on the patient in which they took care of. Next slide.
That concludes all the slides.
Oh, okay, perfect. I couldn't remember. So this is just one of the ways of how we implemented something that is similar in our face-to-face program and structure. So like I said, students are familiar with the structure because every simulation across the curriculum is run exactly the same. The times may just differ. So for example, sometimes we have unfolding cases that have 4 different states. And so that patient will unfold in that manner. So I hope that this has been useful for you, and we are open to answer any questions.
As a reminder for board members, if you have a question, you can either raise your hand or post your question in the chat. For members of our public, you can click on the Q&A icon on your screen and type your question directly into the text box. We have just a couple minutes left for questions. One question is, what are the challenges faculty face while utilizing the simulation modality?
Well, I think one of our biggest challenges was not being able to be in a face-to-face environment. And so I will tell you, when we implemented this, I was a little bit nervous about, were students going to find equal value? Because in our face-to-face program, it's not, the case scenarios are not video recorded. The students are the actual active participants. And what we've actually found is that the students have found it just as valuable, if not more valuable, in being able to observe where something isn't, like I said, the faculty were advised to perform at the level of that student. And so there would be times that students would say, oh my gosh, I can't believe that they did XYZ that way. And whereas other students may say, you know what, I would have done the exact same thing. And we are able, through the debriefing process, to be able to discuss either what would you have done differently if you were in that same situation, or what would you have done that they did or included. But the students have found it to be equally, if not even more effective. And we have found that they obviously, in these pre-recorded videos that they're watching the simulation scenarios in, that they actually don't have the level of anxiety as they did when they were you know, having to perform them as the active participant or in the face-to-face environment.
Right. And I just want to add to that too, the students, just like when Jacqueline on the previous presentation said, the students really appreciate the fact that faculty are in there doing these simulations, and that they're able to see their faculty, you know, perform them. And, you know, based on the surveys that we give our students, you know, they really feel that they are having their direct patient care time, whether we're trying to replace that or not, that they're really meeting those student learning outcomes, and they really feel that they're really demonstrating a high level of engagement. They've appreciated the fact that we've been able to maintain that standard for them.
And one last question, the Sims, are they pre-recorded or live?
So the scenarios, like I had showed you the screenshot, the scenarios are pre-recorded. We had recorded those last summer, and then the actual simulation activities are live on Zoom. So it's myself or another facilitator, the simulation lab specialist, and 10 students. And so the pre-brief and all of the debriefing are all live. And we watch the simulation, the pre-recorded simulation scenarios together in a session. So I hope that helps to clarify. And when I mean live, I mean on Zoom.
Thank you. Thank you so much, Gina and Dr. Amy Vermillion. That concludes your presentation time for today. We are now going to take a brief 10-minute break. Let's see, we'll return back at just about 3 o'clock straight up, and we'll continue on with the last couple items on our agenda for today. We will proceed on with our meeting for today. The next presentation will look to the future with telehealth, and this will be presented by Marie Cordero. Marie, whenever you're ready.
Yeah, I guess I'll unmute myself. That might come in real handy, right? There you go. Anyway, good afternoon, everyone. I'm Marie Cordero. I'm the Supervising Nursing Education Consultant with the Lvnrpt. And I just want to briefly talk to you about telehealth, the role of the Lvnrpt, and a potential role for nursing students to meet some of their clinical objectives. So normally, prior to COVID, healthcare providers cared for their patients in a clinic, a hospital, a medical office, but now we have computers, smartphones, and other new digital technologies, which the healthcare professional can use to diagnose, treat, and oversee their patient's care virtually. So due to COVID-19 and the lack of clinical sites, many programs are requesting approval to include telehealth in meeting some of the students' clinical objectives. And as you can imagine, telehealth has become even more essential during the COVID-19 pandemic for obvious reasons, for fear of spreading and catching the virus during in-person medical visits. Next slide, please. So what is telehealth? I always like to start off with a little definition. So telehealth is a mode of delivering healthcare services and public health via information and communication technologies to facilitate diagnosis, consultation, treatment, education, even care management and self-management of a patient's health. Telehealth is not to be confused with telemedicine. Telemedicine only includes the remote delivery of health care. Interesting, utilization of telehealth has gone up 76% from 35% a decade ago. So there's many ways to deliver telehealth. You may or may not have even used some of these delivery methods yourself in communicating with your healthcare provider. There's the synchronous, which provides and communicates with the patient in real life time being via computer or phone. That's what you all might be familiar with. Asynchronous, data, images, or messages are recorded to share with the provider later. And then remote patient monitoring, measurements such as weight, blood pressure are sent to the provider. Next slide, please. So we do have some advantages and disadvantages of telehealth. Of course, the advantages, it's cost effective, well, for the patient, because you're certainly not getting in your car and driving, and you know, so that would be a cost saving. But I think it's very convenient, number two, because again, sometimes it's convenient, particularly for patients who have mobility limitations or those in rural areas who don't have access to a provider or a clinic like we might have here in the Sacramento area. So those are the advantages. Now, of course, there are some disadvantages. Next slide, please. So you obviously cannot conduct every type of visit remotely. If you have to have an imaging test, if you need to have a chest x-ray, an MRI, a mammogram, well, you can't do that via telehealth. Blood tests, again, unless you're IV certified and draw your own blood at home, I guess you can't do that either. And again, a diagnosis requiring a hands-on approach by the healthcare provider. Sometimes a concern might be the security of the personal health data transmitted might be a concern to some people. And then some services may not be covered by insurance companies. I know I've heard people say that during COVID, which I think is a nice thing insurance companies are doing, that they're waiving the copay if a patient has to have a a telehealth visit. Not my insurance company, but some insurance companies. Next slide, please. So what is the role of the LVN and PT? And of course, this carries on to the nursing student also. What is their role in telehealth? Is there a place for them? Do they have a role? And you know, the reason we're looking at this, again, as I said earlier on in the presentation, that due to the lack of clinical sites, many programs have been requesting approval to include telehealth. And so, you know, we have been looking at those on a case-by-case basis, and provided, of course, that they meet the clinical objectives for that particular student's term or semester that they are in. So the scope of practice of a LVN or PT, they can complete basic assessments. They can gather information and data. They do contribute to the development or revision of a care plan by providing data to the registered nurse. However, the registered nurse is the only one that can develop a care plan. However, the LVN or PT can complete interventions from the care plan that the registered nurse develops, which is within their scope of practice. And another thing I feel is important is they can provide patient education for skills within their scope of practice. And I think that is where I see many students get a very, very good experience providing education, because many times they're reiterating what they've learned in school, and it's almost a learning process for them too. So I think it probably is a win-win. Next slide, please. So, but we have to keep in mind that the LVN and PT, they're not independent practitioners. They must work under the direction of a registered nurse or a licensed physician. Again, and since they're not independent, they cannot independently act on any information that is gathered. Again, they must, they can't independently evaluate data, that they cannot formulate a nursing care plan, make a nursing diagnosis, or decide a plan of care. That is all under the scope of practice of a registered nurse. Next slide, please. Okay, so here's the scope of practice question I'm going to present to you, and I'd like to see if you can answer this. This is taken directly from, we receive questions about scope of practice, a lot. And so one of the jobs that the NECs do is they respond to the scope of practice questions. This came from a facility, and the facility said, our health line exists to triage suspected COVID-19 patients to take the appropriate setting for care. The telephone triage process is delineated and executed by protocol approved by a committee, including nurses, administrators, mid-level providers, and physicians. Oversight is performed by a medical director and clinical RNs. Can a Lvnrpt man a COVID-19 health line per established protocol and has demonstrated competence executing said protocol? Anybody? Yes? No? But not the NECs can't answer. How about a board member? And not Carol Mountain either. Or Donna.
This is Alita Carpenter. I really have no idea, not being a professional myself, but I assume that it would depend on the circumstances, whether there is someone actually overseeing the Lvnrpt.
Yes, thank you, Alita, for stepping up. That is very much appreciated. Anyone else? How about some LVNs, or how about some of our new board members? All right, I might punt this to Carol Mountain then. She might be able to help us out here.
First, I had to unmute myself. Oversight is performed by a medical director and clinical RNs under the oversight of a medical director and with a delineated protocol. I believe that the answer is yes.
Winner, winner, chicken dinner. You are absolutely right. That is correct. That is correct, because it meets all the criteria that I discussed in the other two slides. They are being overseen by an RN or a physician. The triage process, and triage means a lot of times it's just collecting information, and that is within their scope of practice. So yes, they can do that. Okay, next slide. Oh, we're done. Okay, that's it for me. If I'll take any questions now, if anybody has any questions.
All right, we're going to open the Q&A panel again. If you would like to submit any questions, please click on the Q&A icon on your screen and type the question into the text field. And as for board members, you can either raise your hand or enter your questions into the chat field. And let's see. I'm not seeing any questions at the moment. Apparently nobody has any questions at this time, Marie.
Oh, okay, very good.
I
take that back. This is the moderator. There's a couple questions in the Q&A feature. We have a request from Abdul Yosef for question. Are we unmuting people to ask questions, or or should we ask them to type in their questions in that Q&A? And while we wait for an answer on that, we do have a question that asks, how many clinical hours can telehealth replace?
That's a very good question. And again, there is nothing in regulation, and that would have to be, as we say, on a case-by-case basis, and depending on the clinical objectives to be accomplished. For example, I mean, can you accomplish telehealth? Can you accomplish 6 weeks of clinical objectives? Probably not. But it has to be tied to what the clinical objectives that you expect the student to obtain at that clinical site.
All right, and Board Member Norton, I was able to unmute your microphone if you would like to ask your question.
Oh, hello, can you hear me?
Yes, we can hear you.
Okay, awesome. Thank you. So I have, it's kind of a question, it's a question for Marie, and I want to be as polite about the question as I can. But so my concern is in the real world, as a practicing LVN, and also with the controversy that we have seen, especially here in Northern California, with scope of practice and assessment and independent. I mean, those are all buzzwords here in Northern California. But one of the other things that I see happening, and I don't know how we address this, but I wanted to put it out here. How do we across the barrier that seems to be in place, whether it's an actual barrier or a perceived barrier, of LVNs not being able to do a basic assessment or assess, but we now see this emerging where medical assistants, because they don't have a defined scope, they pretty much can do whatever they're trained to do. They're allowed to follow a standard protocol and gather information and be placed in these jobs, or they're allowed to follow an algorithm, but the LVN is not. And I'm not sure if that LVN barrier is due to perception or if it's a real barrier. And so as we're moving forward, it just seems to be a ever-expanding concern that we have. So I don't know if Marie can address that, or but it seems to fit in this conversation, but it may not. So if it doesn't, I'm sorry about that.
No, Donna, I think that's, you know, I agree with you. I think that sometimes sometimes the scope of practice is always not clear. But remember that the scope of practice does not change due to clinical settings. Okay, and if there are some orders, they need to be patient specific with for that patient.
So maybe we can have this as a future agenda item, because like I have a lot more questions related to this, as I'm sure you probably can anticipate, and real specific, like what in this situation, what in that situation, because it does seem to be such a pressing question here. And now as we're moving into telehealth, and as we're moving into, and we're seeing a shortage of nurses now, and I believe that there is an underusage of LVNs. And I think that the only way to address the underusage of LVNs and to get back to the, to the valuation of LVNs is to have a clear understanding of what they are allowed to do, what they aren't allowed to do, so that there's not so much out in the community of deviations from that, either deviations of not allowing them to do what they are allowed to do or allowing them to do what they're really not allowed to do. So I get the fact that the patients, well, perhaps I don't get it. Perhaps, can you explain what you mean by a patient-specific order? I know what I think it means, but I want to hear what you actually mean by it.
Okay, so the patient is myself, Marie Cordero, and the doctor has an order with my name on it for blood draw. That's patient specific.
Okay, so the patient has a specific order for a suture removal in 10 days. Marie Cordero, suture removal 10 days from now. Patient specific order, it is in your chart.
Correct.
Is the LVN, we know they can do suture removals, is the LVN allowed to, in 10 days, remove those sutures?
And yes, if there's an order, that would be, yes, they would be able to do that with a physician's order.
Okay, would the patient have to see the physician that day? Or would the patient have to be evaluated by another licensed personnel, i.e. an RN, before the LVN could act independently? And this is where the word independently comes in, and that's why words are so important.
Right, gotcha. Well, it depends on the order from the doctor. See, that's sort of a little, we need more information. This is interesting that you brought this up, Donna. This is exactly how we answer scope of practice questions and the process we go through. But I think your comment about having perhaps another training about scope of practice is actually very good, and I will make a notation of that.
Okay, all right, and that goes back to my I mean, this has been like the most eye-opening day, and gosh, I wish that we had had all this stimulation when I went to school, because when I went to school, we were the mannequins. We did everything to each other. So I wish that I would have had, like, it's exciting to me to see all of this simulation, whether it's in person, virtual, or whatever it is. And then to add in the advent of telehealth, I mean, where we're going in the future with medical care is exciting, and I just don't want the LVN to get lost in it.
Nor do we. Thank you. Good comments, Donna.
This is the co-moderator, and we are ready to move on to the next item of the day. And this is actually will be our final presentation of the day. And the presentation by Dr. Cindy Fairchild will be from the student perspective. Cindy, I will open your PowerPoint, and then the floor is yours.
Thank you. Good afternoon. Today we have heard vendors share information about their products related to clinical and virtual simulation. We listened to program directors discuss how clinical simulation and virtual clinical simulation is being used during the COVID-19 pandemic. Dr. Spector shared that there is good evidence to support direct patient care experiences. She also shared that a strong, robust, with the keyword robust, clinical simulation program could be used to replace clinical hours. However, there is no data to support replacing clinical hours with virtual simulation. Our mission is to protect the public, and part of the public is the vocational nursing student and psychiatric technician students. Do the students feel supported in the simulated clinical environment? Does the student feel prepared to move into the workforce? What is the student's self-efficacy? The student needs a voice. Next slide. A year ago, we started to hear about COVID-19. By mid-March 2020, the way education was delivered drastically changed. The classroom was no longer on campus, but in the student's home. The instructors scrambled to learn the new teaching modalities and virtual clinical simulation products. Students moved from practicing nursing skills in a skills lab to practicing on a computer. without the ability to develop the psychomotor skills or self-efficacy. The student no longer had the ability to speak with a patient or see the inside of a healthcare facility. When students return to the clinical setting, they may not have any patient care experience other than in the virtual setting. The NECs have been receiving complaints from students related to sitting in front of a computer for 8 to 12 hours instead of caring for patients at a clinical site. Students were saying that they didn't feel as if they were learning anything or felt that they were not prepared to graduate. When NECs conducted a program record survey for continued approval, they began to ask the students questions related to their experience with virtual simulation. Students were making comments such as, "My instructor was not much help. I was not learning anything. This whole thing has been a waste of time. Virtual simulation was helpful, but I still feel the need to have hands-on care to reinforce my learning." The complaints and comments from students led to conversations and thoughts related to how students felt about virtual clinical simulation. The student comments led to the conversations within the education division, which then led to the student survey being developed. The student survey was designed to give the students a voice, to hear how they felt about what was going on. This was not designed to look at virtual simulation as clinical replacement. It did ask if the student was given tools to practice at home, to practice clinical skills at home. The survey, next slide. The survey was designed for approximately 13,235 vocational nursing students and 550 psychiatric technician students, a way to share their feelings. The survey looks at student satisfaction and self-efficacy. Again, not at virtual simulation as a clinical replacement. The survey was conducted via SurveyMonkey from January 26th through February 10th and was completely anonymous. Thereby, a student nor the school could be identified. The link to the survey was sent to the program directors to disseminate to their students. During the 2 weeks of the survey was open, 874 students responded. Next slide. The first question asked the students which content area they were studying. 44% of students selected Med-Surg, 23% of students were in fundamentals, 15% of students were in maternal, newborn, or peds, and 19% of the students had already graduated. The next question asked the student what kind of products were they using for clinical replacement. Majority of the students said ATI or Shadow Health. The next 4 questions were a Likert scale question asking the student if they agreed, strongly agreed, neither agreed nor disagreed, disagreed, or strongly disagreed. The third question in the survey asked if the student was given the tools to be successful in simulated clinical experiences. More than 65% of the students agreed or strongly agreed that they were given the tools to be successful, while 17% said that they disagreed or strongly disagreed. The fourth question asked if the instructor was supportive. More than 73% agreed or strongly agreed that they had a supportive instructor, and 11% disagreed or strongly disagreed. The fifth question was the instructor's knowledge related to simulation. And as we've heard through the day, there's a lot of transition and quick learning to be able to move to these modalities. The students said 72% of students agreed or strongly agreed that their instructor was knowledgeable, while 13% felt that their instructor was not. The next 2 questions had to do with self-efficacy and being prepared. With virtual clinical simulations, preparing them to provide safe patient care. Only 62% of students felt that they were prepared, when 20% said that they did not agree. The 7th question asked if clinical simulated experiences gave them the confidence to enter the workforce. Only 53% of the students said that they agreed or strongly agreed, while 25% of the students felt that they were not ready to enter the workforce. Next slide. The last 3 questions ask students to share what they liked best and what they liked least, as well if there was anything else that they would like to share. The common comments related to what they liked best included, it's always available, I can go back and practice on my own, I didn't feel as pressured or intimidated while asking questions, I could get immediate feedback, this is the best time to make mistakes and learn from them instead of with a real patient. I was really able to hear the lung sounds and different GI sounds. Common questions that, common comments with what they liked least included the lack of hands-on experience. There was no human interaction aside from talking to their instructor. They did not feel it was real. They felt like there was no emotions. Some said that the simulations were complicated, while others said they didn't feel it prepared for all situations. The final question asked if there was anything else that they would like to share about their simulated clinical experiences. The trends for this question included these resources provide a better understanding in my learning. Overall, great experience. In person is always better. I am grateful that this is available to me. It is difficult to feel prepared for real clinical setting or being on the floor when we are learning from simulated clinical experiences. And a lot of students said something along the lines of, I want to go back on campus full time. Approximately 70% of students feel that faculty are knowledgeable and supportive, that they had the tools given to be able to work with and in a virtual clinical simulated environment. However, only 53 to 62% of students felt that they had the self-efficacy to provide safe patient care or to enter the workforce. Thank you for listening to the voice of the student. Any questions?
We are going to open up our Q&A panel one last time. Again, members, please raise your hand or type your question into the chat field. And for members of the public joining, you can type your question into the Q&A field by clicking on the Q&A icon and typing into the text field. We do have one comment from board member Norton. It says, from my take on this is that simulation, whether in person or virtual, should be used as a supplement to in-person clinical rotation. To that effect, there needs to be a better collaboration between facilities, schools, and students to ensure that we have quality clinical experience.
Thank you, Donna. As far as the virtual simulation, you're absolutely right. There is no research to show that this can be clinical can be replaced with virtual in the long term. There is some really good and a lot of research that shows a good, robust, again, that keyword is strong, robust simulation program can be a replacement. When you've got a really good program, your students stay engaged, where in the clinic setting, there's more downtime at times, where with the clinical simulation, there is not the downtime. The student stays engaged. But back to the keyword, it has to be a robust program to replace the clinical hours.
And one question that's come in, will the data from this survey be released so that it can be reviewed?
I can release it to the board members or to whoever, Elaine and Marie. I did not go through it. I just received it on the 11th, 12th. So I did not do a extreme fine detailed as to evaluation of it. I looked for trends. I did not look to see if there was different responses between med-surg students that graduated, fundamental students to their answers, but I do have the raw data from the survey.
And the next question, how would a fundamental student know what it means to be prepared to enter the workforce?
There were a lot of students who did not answer the question on that, and I do believe that a lot of them were the fundamental students. So, but you're right, they are still growing and still learning.
And let's see. Shouldn't programs include a mixture of all three in person, sim, Vsim, and live clinicals? Sim will never completely effectively replace live. And the question with that is, what are the next steps for virtual simulation evaluation or guidelines moving forward?
At this time, there needs to be more research. As Dr. Spector said this morning, they have some research studies, and until there's some good solid evidence, there wouldn't be any moving forward with virtual clinical simulation.
Okay, and a question that this one popped up kind of at the end of Marie's presentation and going into yours. Given the terrific benefit presented today of Vsim, will the Lvnrpt allow for Vsim to remain as an integral part of our curricula post-pandemic? The decision-making and clinical reasoning that is safely accomplished via Vsim is amazing.
Hi, this is Marie. Well, again, no decision has been made. And again, as Cindy said in her presentation, we have to collect more data, and I think we need more information. I mean, anything's a possibility. And again, our goal is the education of nursing students, and we want to make sure that they're prepared adequately. If that's hands-on, if that's Vsim, if that's a combination, then we have to look at everything as a whole.
All right, and we have a comment from Board President Mountain, which is, the voice of the student is so important. Thank you for sharing this. I think it reveals so much about the student perception. And we also have one other question that was sent in. Any decisions on keeping theory in an online format post-pandemic?
This is Marie. I guess I'll answer.
Thank you.
Yes. Well, again, all I ask is be patient. Let us get through this pandemic first, because the NECs are like so overworked. It's amazing. And again, there's always a possibility. I mean, we are open to any discussions that, again, would provide the best education for the nursing student.
Thank you, Marie and Cindy. Seeing no additional questions coming in, I'm going to pass this over to President Carol Mountain and Executive Officer Elaine Yamaguchi for closing remarks.
Thank you so much. I want to say again, the entire presentation has just been so full of great information, and I hope everyone has enjoyed it as much as I have. I want to thank all of the presenters and all the work they put in to make this so that it was very interesting and understandable, even to those people that don't work in education or haven't used these modalities. So thank you very much to each one of them. And thank you to everybody for coming and being supportive and asking great questions. And I hope you took away a lot from this. I'd like to turn it over to Elaine.
Thank you very much, Dr. Mountain, and all of you really for your time and your interest and your engagement, and especially the very, very active and inquiring minds of all our board members. You know, we were so pleased to be able to provide, well, I've described today as both an informational fire hose and a casino buffet of food for thought. But truly, we're, as I said earlier this morning, we are really, I think, just on this precipice where, you know, all the questions just, you know, a few minutes ago of, well, are we going to be able to continue this? Are we going to, has there been a decision about this? You know, no, we haven't been able to make any decisions. We haven't had like a really, I think, an opportunity to provide any kind of analysis of what's been going on. But I have to tell you that I've been so impressed with what the products are capable of doing now. And I was so impressed with the presentations from all the programs of how they've really responded in this pandemic, and how neatly they've synthesized the old with the new. So I think what it's fair to say is we're not going to rule out anything, you know, in particular, but we're also not going to say a hard and fast percentage until there's been a lot more research and analysis and a lot more discussion. But I do think that, and actually I think Board Member Norton summed it up best, there needs to be some balance. And I think the NECs who have been working with the programs would also agree with me that it just needs to have some balance, and it needs to be shown to be an effective means of teaching. And as an old-time activist, I would also say that I strongly believe that the inclusion of the student opinion and efficacy is essential in making these programs move into the next era. So I wanted to close out the session again, thanking everybody for their time and attendance. And you know, one of the only bad things about this virtual platform, of course, is that we can't give everybody a rousing round of applause. So please just consider doing that on your own. But I wanted to make a special thank you to Shelley and to Sarah and to Brittany Ortega over at Solid, to our own Vicky Saavedra and the team NEC, who did such a fabulous job of wrangling this program together. So thank you, everybody. And this is going to continue. This is the beginning of a conversation that's going to last probably years. So anyways, again, thank you so much. We hope to have the materials posted within the next few days. Take care, everybody, and stay safe out there.